Good day and welcome to the September Lunch and Learn focusing on the role of bone marrow transplantation in blood cancers conference call. Today's conference is being recorded. At this time, I would like to turn the conference over to Jennifer Gillette. Please go ahead.
Hello, thank you so much. Yes, my name is Jennifer Gillette, and I am the staff social worker at the National Bone Marrow Transplant Link. I'd like to welcome you all to our call today. This month's speakers will focus on the role of transplantation in blood cancers and how to navigate through this process. Today's Lunch and Learn, again, will be recorded, so during any portion when we have questions, make sure you refrain from using your last name. It is our goal that today's program will inspire you with ideas that will equip you with a new skill as you learn how to navigate through this journey. A special thank you to Genentech and the Leukemia and Lymphoma Society for making this program possible today. We also thank our LINK partners for their supportive efforts. For those who may not be familiar with the LINK, our mission is dedicated to helping patients, caregivers, and their loved ones from the time of diagnosis through survivorship by providing educational resources and emotional support. We work with hospitals, cancer centers, and other organizations to reinforce and complement medical care. Some of the resources we provide to help families navigate the transplant journey are printed publications, including our resource guide that holds an abundance of helpful organizations for financial assistance and other needs one might experience on the BMT journey. And additionally, you may access our recordings of previous programs on topics such as caregiving, chronic graft versus host disease, financial planning, and others. And I am here as a licensed social worker to give you information and emotional support. I'm also happy to educate you on our peer support program. Before we begin today's program, I would like to review a few housekeeping items to maximize the experience for everyone on the call today. First of all, please keep your phone on mute if you are not speaking. This is especially important during the question and answer period of the call. There will be time at the end for you to ask questions, and we'll do our best to get to as many as we can on the call today. But if for some reason we are unable to get to your question, you're welcome to email it to us, and we will do our best to try to get it answered. Also, we will strive to create an atmosphere that allows for all to participate. So due to a limited amount of time and with a desire for everyone to have the opportunity to participate, the facilitator might need to shorten any questions that go longer than needed. Please also refrain from any judgmental statements towards fellow participants, respecting that everyone handles this experience in their own unique way. And please also know that the information provided in this program is meant to stimulate conversation with you and your healthcare provider. It's not meant to replace your individualized medical plan. So today's outline will go as follows. We had a few minutes for introduction. We'll have Dr. Giralt speak for about 15 minutes. Then we'll have a survivor and professional nurse educator, Dulce Wilson, speak. And then we'll open up the floor for questions for approximately half the program. And then just a couple minutes at the end to tell you some additional resources and wrapping up points. Okay, without further ado, I'd like to introduce you to our first speaker. We are extremely honored to have Dr. Giralt, of the Chief of the Adult Bone Marrow Transplant Service in the Division of Hematologic Oncology at Memorial Sloan Kettering Cancer Center in New York. He is affiliated with Cornell Medical College as a professor of medicine. He is board certified in internal medicine and hematology, and he holds membership in several professional societies and key positions in several organizations. Dr. Giralt has published over 400 articles and abstracts in the peer-reviewed literature and written chapters for several books. On behalf of the LINK and those who get to benefit from your expertise today, I thank you so much for joining us today, Dr. Giralt.
And thank you very much. It's a true pleasure to be here, and I want to welcome all the persons who are listening to this. So I was asked to talk about, curing blood cancers in general. And I think we should start with, well, what's blood? I mean, blood is, that tissue that we all have that circulates through our blood vessels that, does an enormous amount of things. It carries our nutrients from one place to another. It carries the red blood cells that carry the oxygen to the different organs. It makes our white cells, which are the soldiers that defend us against infection, go to different places. And it carries the platelets that are those elements of the blood that prevents us from bleeding. Now, what's interesting is blood is a very complex tissue. It's formed by a fluid phase, which is the plasma that has the proteins, and a solid phase, which are the cells. Now, all these cells derive from the same mother stem cell that, starts in the embryo when we were, initially conceived by our parents. So as this stem cell matures, it decides it can become one of two fates. It can become a lymphoid precursor, and it produces the T lymphocytes and the B lymphocytes, or it can become a myeloid precursor. And that myeloid precursor will then have three fates. It can become a white cell to defend us against infection. It become a red cell that produces the erythrocytes that transfer oxygen throughout the body, or it can become a megakaryocyte that then produces platelets that prevents from bleeding. Throughout all that maturation procedure, there are a lot of complex genetic changes that happen. And in every given moment, there may be a genetic damage that can occur that can lead to malignant transformation, so that these cells can actually become cancerous. Depending on when that genetic transformation happened, we will see a different type of blood cancer. So if the genetic transformation happened in a mature lymphocyte, we can see lymphoma, myeloma, or other lymphoproliferative disorders. If it happened in a very premature lymphoid precursor, we'll see acute lymphoblastic leukemia. If it happens in a myeloid precursor, we will either see acute myeloid leukemia, myelodysplastic syndrome, or other myeloproliferative disorders. Now, these genetic changes are always happening, and our immune system is actually very effective in getting rid of them. So only when our immune system is incapable of recognizing these transformed cells as abnormal do we eventually get the development of the disease. Now, there are many ways that we have actually been very successful in curing blood cancer. The most common way that we have been successful in curing blood cancer is using combination chemotherapy. This was first described in the 1960s by Dr. Fry and Freyreich, in which they showed that in children with acute lymphoblastic leukemia, if you combine steroids with vinca alkaloids or with methotrexate, you could actually cure children with this disease. Up to then, the tradition had been give one drug at a time to avoid toxicities. They made the paradigm shift in saying, no, the way to cure this disease is giving them all together to prevent resistance. And we actually, because of combination chemotherapy, can cure most patients with acute lymphoblastic leukemia of childhood, many patients with Hodgkin's disease, many patients with non-Hodgkin's lymphoma, or many patients with acute myelogenous leukemia or acute lymphoblastic leukemia. Unfortunately, we can't cure all of them, and for many patients, the disease comes back. And if that situation is where high-dose chemotherapy and stem cell support has been used as a curative strategy or as a strategy that can change the natural course of the disease. If we think about how this strategy came about, we have to go back way to 1949, when the Russians successfully developed a nuclear weapon. At that time, the Department of Atomic Energy spent an enormous amount of resources and supported a lot of very, talented researchers, asking them the question, how could we defend populations against a potential nuclear attack? And it was Dr. Don Thomas, who then became the Nobel Prize winner in 1990, together with Professor George Maté, who came up with the idea that we could use high doses of radiation to get rid of leukemic marrow. But to be able to rescue the patient from the high doses of radiation, we need to actually transfuse or transfer the bone marrow from another person into them to be able to rescue them from the side effects of high-dose radiation, which were primarily elimination of the marrow. Unfortunately, during the first 25 years of marrow transplantation, we didn't have enough knowledge. And out of the first 400 patients, only 4 survived. It was afterwards, with development of isolation rooms, better antibiotics, central venous catheter, our understanding of tissue typing, that finally in the 1970s, Dr. Bob Good performed the first successful transplant in a child with severe combined immune deficiency syndrome, or what you know as the boy in the plastic bubble. Later on, Dr. Don Thomas showed the first 100 patients with refractory acute leukemia who survived and lived, after a transplant being cured from their disease. A total of 25% of patients were long-term survivors. In this first experience, published in 1975, the oldest patient was 30 years of age. And for many, many years, it was thought that transplant had to be limited to younger patients who were fit because nobody would be able to tolerate the high doses of chemotherapy and radiation required to be able to eliminate the malignant cell. In 1975, I was part of the group at MD Anderson, in 1995, was part of the group at the MD Anderson that led the development of the reduced intensity conditioning regimen. In this strategy, we said the transplants work 2 ways. 1, by giving high doses of chemotherapy and radiation, but 2, by giving a donor's immune system that can recognize the disease as foreign and prevent it from coming back. These reduced intensity conditioning regimens now allow us universally to perform transplants in patients up to the age of 80. So there are 2 types of transplants. An allogeneic transplant in which a third party is a donor, and an autologous transplant where the patient serves as their own donor. The most common indication for an autologous transplant is multiple myeloma, more than 8,000 performed every year in the United States. The second most common indication for autologous transplant is non-Hodgkin's lymphoma. In an autologous transplant, the patient serves as the donor, and the main therapeutic effect is the high-dose chemotherapy that can eliminate cells that are potentially resistant to the conventional chemotherapy that the patients had received so far. In an allogeneic transplant, a third-party donor is used as the source of blood stem cells. And then patients can receive either high-dose or reduced-intensity chemotherapy, and the cells will engraft. We need to train those cells to live in the patient's body. And to do that, there are many strategies that are used to prevent a disease or a complication that's called graft versus host disease. But graft versus host disease has a good side, because graft versus host disease also mediates graft versus leukemia effect. Now, we and others have been successful in separating graft versus host disease from graft versus leukemia. And that's why allogeneic transplant can cure many patients with acute myelogenous leukemia, myelodysplastic syndromes, and acute lymphoblastic leukemia. Currently, the most common indication for an allogeneic transplant in the United States is acute myelogenous leukemia, followed very closely by myelodysplastic syndrome. We divide transplants in 5 phases. The first phase is what we call, before the transplant, we do what we call the pre-transplant phase, in which patients are assessed for organ function. The decision is made is whether they should undergo an autologous transplant or allogeneic transplant. If a decision to make an allogeneic transplant, then we pursue to see which is the best available donor. In general, a best available donor is a brother or sister who happens to have your same tissue type or your same HLA type. You have 10 HLA numbers, 5 from your mother, 5 from your father, and you're looking for somebody who has those same 10. Usually, a brother or sister will have a 1 in 4 chance of having the same 10 numbers. If not, we have created large volunteer registries where patients can go and see if there's a volunteer donor who has the same 10 numbers. This is Be the Match, or the National Marrow Donor Program, or what you other knows as the Bone Marrow Transplant Registry. In 2018, everybody should have a donor, because the group at Hopkins has developed strategies that allow us to do mismatch transplantations very successfully, and the cord blood banks and the unrelated donor banks are large enough that we should be able to find a 9 out of 10 donor for almost everybody. Now, The transplants, again, are divided in 5 phases. The first 3 phases are common, whether you're getting an autologous transplant or an allogeneic transplant. The first phase is the chemotherapy phase, which patients receive high doses of chemotherapy with or without radiation, and we're very good in controlling the acute symptoms. The second phase is what we call the low-count phase. Here, patients are feeling the effects of the high doses of chemotherapy. Many times now, we actually can perform the transplant as an outpatient because we're very good in controlling the mouth source of pain and keeping patients hydrated, and we have specialized outpatient transplant units. But in many places, patients are in the hospital until the counts recover, and that is phase 3 or early recovery. In the autologous setting, this usually marks the beginning of the discharge from the transplant center for the patient. In the allogeneic setting, the patient is discharged but requires to stay close by to the transplant center as we monitor the recovery of the immune system. We make sure that the patient's not developing graft versus host disease, and we're monitoring and adjusting the medications that we use to train the patients to train the patient's donor cells to not reject the patient and cause graft versus host disease. In this setting, because the immune system is also very immature, we're constantly monitoring for viral reactivation. The treatment has improved dramatically. We now have survival rates which are universally above 80% for patients with marrow failure syndromes, 50 to 60% for patients with leukemias that are in remission. For patients with chronic myelogenous leukemia, the survival rates are over 75 to 80%. For patients with active disease, we have a lot to work on. Although we can cure 15 to 20%, many of the patients unfortunately relapse after transplant. And we now have major research enterprises and major research efforts to try to develop maintenance therapies with either cellular immunotherapies or drugs to prevent the disease from coming back. Transplant has evolved dramatically over the last 40 years. We are finding ways to improve access and increase access and improve outcomes. One of the areas of my research focus is to make transplant easier. And one of the ways we're trying to make transplant easier is to reduce symptom burden, particularly fatigue. And there are new strategies that we can use that will allow patients recover quicker and go back to their normal lives. I want to once again thank you all for your attention, and we'll stay on for the question and answer period.
Oh, thank you so much, Dr. Giralt. You make something so complex understandable, and I really appreciate it.
I thank you very much.
Yes, and supporting the patients on this journey. I now would like to introduce everyone to our next speaker, Dulce Wilson. At the age of 18, Dulce moved away to college when she began feeling ill. And after several months of progressive illness, she was diagnosed with CML. In 1997, the only treatment option for CML was a stem cell transplant. Her one and only brother proved to be a perfect HLA match, and she underwent an allogeneic transplant in March of 97. After a 2-year-long road back to recovery, she was finally able to return to school in December 2003. She graduated from California State University with a Bachelor's of Science in Nursing, fulfilling a lifelong goal of becoming a nurse. In January of 2004, she returned to the hospital, Sutter General Hospital in Sacramento, where she had undergone her transplant as an oncology and bone marrow transplant nurse. In 2006, she married her best friend, and in 2009, she welcomed their miracle baby into the world after years of infertility and miscarriage, all secondary to her treatment. In 2011, she became the clinical nurse educator for oncology and BMT, and in 2014 proved to be a busy year as she graduated with her master's in nursing education and became Woman of the Year for the Leukemia and Lymphoma Society. Since 2015, Dulce has been very involved with the Leukemia and Lymphoma Society as a facilitator, lobbyist, and event participant. Welcome, and thank you so much, Dulce, for joining us today.
Thank you so much for asking me to be part of this great program. I'm thrilled to be part of this. As you heard from my bio that Jennifer just read, I come to you today from 2 different perspectives. First and foremost, as a patient, and happily as a survivor. Next, I'm an oncology certified clinical nurse educator, and I've spent my entire 15 years as a nurse in oncology and blood and marrow transplant. and I'd like to share with each of you some of the things that have helped me continue in my progression of survivorship and to help my patients each day. As a patient, especially a young patient, it was overwhelming to walk into my appointments with my oncologist and be slammed with information that was so new to me. My oncologist actually told me that it's actually proven that patients only remember approximately 25% of what is discussed at each appointment, especially when they're faced with a new diagnosis, change in prognosis, or treatment planning. To help you remember what is discussed and to help you get your questions answered, there are some tips that we encourage. First, have them come with you to your appointment. It's intimidating to be there by yourself, and having a support system is always important. Those people are likely to hear things that you may have missed, and oftentimes I hear patients say they always forget their questions when the doctors actually come into the room. So whether this is in a clinic setting or in the hospital, I always recommend that my patients write down the questions as they think of them. Keep a pad and pen next to your bed, or in this day and age, open a note page on your phone and type it in. Most of us are not too far from our phones. Lastly, please remember all questions are really important. You might think that they seem simple, but if it's important to you, it's important to your care team. During transplant, there were some recommendations that I received for helping me cope through the process of transplant. It's a long process, and sometimes you get really bored. You're not feeling your best, and so it's hard to do some of the things that were normal for me. I was recommended to bring in, I love art, and I was recommended that I bring in my art projects and have something to keep myself busy. For me, this wasn't really realistic. I was shaking a lot and had a hard time concentrating. I love reading, but that was difficult for me too. The concentration, the medications we give patients don't really allow them to focus really well on some of those things. Puzzles and games were fun for me. I was able to set it aside when I got tired, but it gave me something to do that didn't really require me to really think too much. I watched a lot of movies just to pass time, but one thing that was really important for me was music, and we actually have a really great music therapy program that we use with our patients. It was able to help myself calm down and let me feel normal. Again, I was a teenager, so music was an important thing in my age group. But it also helped me eliminate some of the other sounds that I could hear from the unit, especially when I was trying to go to sleep. A lot of people think, I'm going to be in the hospital and I'm going to get a lot of rest, and that's not super realistic. We actually don't let our patients sleep too much because there's things that we need to do to take care of patients. Another thing for me was just helping myself get through it, stuff I tell my patients every day. It's really important. There's a few things that you can do to help yourself during the transplant process that medicine, the doctors, the nurses, those things we cannot help you with. We might encourage a lot, but you need to be an active participant. Walking, getting up and keeping your mobility and your strength up is really important. It's really easy to become deconditioned while you're laying in the bed. Remaining active keeps your lungs open and helps prevent pressure ulcers, and it just keeps your muscles strengthened, which is really important when you go home and on your road to recovery. Showering. Most of our infections actually occur from the normal flora on your body, on your skin, and also it makes you just feel better if you get up and clean yourself up. I was in the hospital for 36 days during my transplant admission, and I only spent one day not showering, and that was actually the worst day I felt. Other things that you can do is oral care. The chemotherapy can be really harsh on your oral mucosa, and keeping your mouth clean can help prevent infections and helps maintain your nourishment because you're able to keep food in. Patients really kind of take that for granted until you really experience the side effects of the chemotherapy. And one thing I cannot stress enough, I say this to my members in my support group, I say it to my patients, you have to remain positive through this process. It's a long and rough road, not going to lie, but remaining positive really does affect how your outcome will be. It doesn't matter what the doctors or the nurses can do. It doesn't matter if you have a perfect HLA match. If you don't think you're going to do well, you won't do well. If you remain positive and believe that you're going to do it, you will. I've seen this with many patients. I took this thought when I went through my own transplant, and maybe it seems naive to some of my family members that I never thought I wasn't going to do well, but I really do believe that it helps me and it helps motivate me to stay positive and get up every day and do what I needed. And remember that we tear you down during the transplant process. You are going to feel very sick, but we're doing that. We're tearing you down to build you back up and make you into a stronger person and make your immune system stronger. And honestly, this is just a bump in the road. Albeit a large bump, you can do it. There's many of us that have gone through this process. I try to tell my patients this every single day. I am a resource for my patient as a nurse, but also as a patient, and it's really a positive influence for them. And I think that's pretty much all I want to share. I will be here for questions.
Great. Well, thank you so much, Dulce. That's a lot of wonderful tips for people to take in today as they're going through this. So, yes, now we will open up the call to questions, and I'll let Audra lead that. Thank you so much.
Thank you. If you would like to ask a question, please press star 1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach the equipment. A voice prompt on your phone line will indicate when your line is open. Once again, if you do have a question, please press star 1. And we'll go to our first question.
Hi, I have a question. I'm calling from Denver. Can you hear me?
Yes, we can hear you.
Hi, thank you for doing this. It's my first call. I have CML. I was diagnosed a little over a year ago. I'm on 100 milligrams of Sprycel. I just had my first-year biopsy, and I'm in almost full remission. They found my BCR under 0.011. The Sprycel makes me very nauseated, and I've lost a lot of weight. It's Colorado. My oncologist legally is allowing me to use cannabis for nausea and appetite, and I use a patch during the day, and at night I take something. I don't smoke it because I don't want to. My question to you is I've been told here in Colorado that some of the non-psychoactive parts of the cannabinoids actually help with the treatment of mitigating the cancer cells for blood cancer. I know it's not legal and there's not a lot of research around this, but I was wondering if you could comment at all about my question, if that's actually an effective approach.
Dr. Giralt, would you like to start with that one?
So I'm gonna talk to the general aspects of this, then because I tend to avoid speaking to any specific patient issues over any of these webinars. And one is there's a lot that we don't know about cannabinoids, both the naturally occurring and the synthetic ones. I think we all agree that the ones both the synthetics and the natural occurrence have been very effective in managing many of the symptoms. There are no large studies to see how they may affect or may not affect anti-cancer. I think you do the right how they affect or how they interact with cancer treatment. I do think you're doing the right thing by not smoking it, because I do think that the natural occurring smoking marijuana has other chemical ingredients that actually may be harmful to the lungs, and there actually may be bacterial contaminants. So I think as long as your doctor's prescribing you for symptom control, it's probably fine, and obviously you're responding well to treatment, so I don't think you have anything to worry about in that regard.
Wonderful. Thank you. So continuing to use that as prophylactic for my nausea or whatever, and also hoping that it actually has some medicinal approaches is not wishful thinking, it sounds like.
I would say, I think the most important thing is by controlling your symptoms, it gives you a good mental attitude, and that is important for what your outcome's going to look like.
Thank you.
Thank you. Okay, we'll take the next question.
We'll move to our next.
Hello.
Please go ahead.
Hello. Yeah, my name is Girish. I was diagnosed with acute myeloid leukemia back in April 2017. Went through induction and then 4 cycles of consolidation chemotherapy, relapsed after the 4th cycle, and now looking at the transplant option as the only hope, I believe, for cure. The question that I have is 2 things. One is, as I'm preparing to go into transplant, I have developed fevers of unknown origin, which basically, with every test under the sun, have come out to be negative in terms of bacterial tests, bacterial infections, viral, etc. So my question is, does that affect the transplant process? And the second question that I had is, I personally am CMV negative. If the donors that are available to me are CMV positive, how does that affect the outcome of the transplant?
So again, I will refrain from answering any specific questions that are particular to a patient, but I can talk to you in general aspects. So as patients come to transplants, they have to be in the best medical condition possible, which usually means most medical situations have to be stabilized or under control. A fever could mean an uncontrolled infection, but it also could be a manifestation of your disease. Your transplant physician will decide based on evidence whether it's one or the other, and that's a decision that he or she will need to make. In regards to the CMV issue, although we would like to have a CMV concordant donor, the results of getting a CMV negative patient getting a CMV positive donor are not bad. They're actually almost as good, and there's a new drug called letermovir that can be used to prevent CMV reactivation.
Okay, and in terms of that drug that you just referred to is just as effective, meaning there are other side effects to that drug that me as a patient would experience?
There can be, but again, this is a specific question that you should ask your transplant doctor.
Okay, thank you.
Thank you. Okay, we'll take our next call.
And we'll go to the next question. Please go ahead.
Hello?
Oh, we hear you.
Oh, okay. Back in 2012, I had a haploidentical bone marrow transplant, which at the time were not very popular. Johns Hopkins at the time was 2 years into a clinical trial with it, which I was not part of. I came just after that. Obviously, it was successful. I'm still here. And I was just wondering, because it was obviously a life-saving event for me, I'd like to know how many of them are now being done.
So post-transplant cyclophosphamide that was pioneered by Johns Hopkins has been what we call a transformational technology. It's transformational because it now has allowed for successful mismatched transplantation, not only with a related donor, but also with unrelated donors. It also is one of the most cost-effective ways of performing transplants, and for many third world countries, it is the only way that donor transplants can be performed. And in many ways, it may be cheaper than, traditional chemotherapy. So it is, it has actually now it's being compared to other more traditional ways of prevention of graft versus host disease in a large national study. All of us are thankful to the Hopkins team. And again, this was supported by research funds that developed this technology, and which is very, very, cyclophosphamide is actually very cheap. and it allows now to transplant successfully people without a fully matched donor.
How is it less expensive? Because I thought the process in terms of time was very similar. I mean, I spent a month in the hospital in isolation.
Because if you get less graft versus host disease, chronic graft versus host disease is a very expensive condition to treat.
Okay, yeah, and I did. Mine was very minor. So it is being used more nationally now?
Across the country. It's the most rapidly growing technology for mismatched transplant.
Well, hopefully I had something to do with that, my success. Thank you.
Everybody who participated in a clinical trial and everybody who allows their data to be shared with the registry is helping us get better.
Thank you so much. Okay, we'll take the next caller.
Next caller, your line is open.
Hi, I'd like to thank everybody who participated today for helping those of us who have been diagnosed. I was diagnosed in 2016 with CMML, and February of 2017, I had a stem cell transplant with a 10 out of 10 match from my sister. With that being said, I had 5 follow-up donor lymphocyte transfusions, and unfortunately, with my last bone marrow biopsies, the DNA markers are still there. So at this point, I'm being educated and considering options that I'm being given, one of which would be continuing chemotherapy until it stops working, and the other would be a second stem cell transplant, a haploid transplant with my son's stem cells. And then it was just brought up by Dr. Giralt that on the Be the Match or the National Registry, there could possibly be a 9 out of 10 match. So I was wondering which might be better if we could find a 9 out of 10 match or go with the 5 out of 10 that would be my son's match.
So again, and I apologize for this, but it would be very irresponsible of me to making specific comments of situations and patients I haven't seen. So I address this issue in a general way. Unfortunately, relapse is the most common cause of treatment failure. We will have in Chicago now a national meeting. This is the third of many where we're trying to find strategies to prevent relapse. Now, one has to distinguish relapse from mixed chimerism. So many patients can have residual donor cells but not have disease recurrence. So in many cases, we have patients who they have normal donor cells and normal host cells themselves, but there's no evidence of disease coming back. And sometimes it's not, and what we've told patients, look, as long as your counts are normal, as long as you're asymptomatic, and as long as we really have no definitive evidence that your disease is coming back, many times we just don't treat mixed chimerism, we just watch it, or unless we feel that the graft is going to fail and your counts are going to drop. Now, in patients who have relapsed after transplant, there is many potential therapeutic strategies. One is, just treating the disease and seeing what happens, or the other is second transplantation. There is no definitive data that one strategy for second transplantation may be better than another. So in this situation, I suggest that you sit down with your transplant physician and talk about the pros and cons of each of the strategies that they propose, including doing a second transplant from the same donor, which many times are successful and for which there is no evidence that, one might be better than the other. Although, intuitively you would say that you should look for another donor. We don't know how much benefit that will give you.
Okay. Thank you. In reference to that, my donor is not available for transplant, so we would need to then go somewhere else.
So then there's many, and then so I think you need to discuss the option with your doctor because there are pros and cons of each of those strategies but they're all reasonable.
Absolutely. Thank you so much. And Dulce, I'd like to thank you for your input. Everything you said is right on target, from the exercise to the positive attitude to the music. It all worked for me, and I don't have any bad memories of any part of the 30 days in the hospital. It sailed by, and I've been short of having chimerisms dropping and the bone marrow, the DNA marker still there, I've not had any illness or anything. So I've been one of the ones that have, been blessed with positive outlook and outcome. So thank you all very, very much for doing this for us today.
Oh, thank you. And thank you for sharing your testimony. That's good to hear.
And we'll move to our next question. Oh, that questioner disconnected. We'll move to our next question.
Hi, this is Natalia, and I have a question about Dr. Sergio Giralt previously mentioned statistic rates. And I just wanted to know, are those survival statistic rates or are those cure statistic rates? It's above 80% for marrow failure, 50 to 60% for leukemia in remission, and 15 to 20% for active disease.
So those are, what we would call 5-year disease-free survival rates. And traditionally we have said that if the disease does not come back in 5 years, you're cured. That's not 100% certain, but the risk of relapse decreases significantly after 5 years.
Okay. That was my main question. Thank you.
Thank you.
Move to our next question.
Hello. My name is Valerie, and my niece was diagnosed with ALL 11q23. She's 34 years old, and it's just been a struggle, but she is scheduled for transplant October 5th, even though she seems not to be able to get stable, but she was first on the traditional treatment for chemo, the hyper CVAD, and was transferred to be close to her mom, and they're treating her with the Larsons. Every time she gets chemo, she winds up in the ICU with either sepsis or E. coli or something. She has CNS involvement. And the bone marrow component, I'm just trying to be a helpful family member and support the post-care. But two questions. The 11q23 involvement, very little is published specifically to that genetic trigger or whatever happened there. Does that mean that this is a poor prognosis, or what is the impact of the 11q23?
I think you're seeing it, the fact that she's not achieved a quick remission and that you're talking about transplant. So it just shows you, once patients have failed to respond to primary therapy, the cytogenetic is less important than the fact that they haven't responded optimally to primary therapy. But traditionally, the 11q23 has been considered a poor prognostic feature. But with modern therapy now, many of these patients do not require transplant. The most important measurement that we use to decide whether a patient with ALL should consider transplant or not is the presence or absence of minimal residual disease in 90 to 180 days post-induction treatment.
Yeah, unfortunately, this is the 3rd month, maybe 4th. And we just haven't had good remissions and lots of complications, particularly from the Larsons with the hepatic enzymes. And does the CAR T-cell, is that widely used now? That it's post-bone marrow?
It's available for patients less than 25 years of age with refractory ALL.
Okay, she's 34, so would that be an option for her?
No, she'd have to talk to her doctor and see if there's an investigational option available.
And would you be doing that if this were your family member?
I think, again, this is something that they need to talk to the doctor about. We're getting into specific recommendations for specific patients, and I don't do that.
Mm-hmm. Okay.
I'm sorry.
Okay, thank you.
Thank you. And just a reminder to everyone, and to echo what Dr. Giralt is saying, when he doesn't see a patient directly, there is a whole chart of information that he doesn't get to see. So it's really not something that he can give specifics on. But we certainly appreciate the generalities that you're offering today, Doctor. Okay, we'll take the next call.
And caller, your line is open. Please go ahead. And if you heard a voice prompt on your phone line, your line is now open. You may be on mute. Hearing no response, we'll move to our next question.
Hi. Can you hear me?
Yes.
Yes.
Okay. Great. Thank you. Thank you all so much for putting together this call and to the speakers. I'm the caregiver of my mother who has angioimmunoblastic T-cell lymphoma, has completed 6 rounds of CHOP, reached remission, and we're now awaiting a decision of auto or allo transplant. And so my question is a little bit related to that decision. So the first is, well, they're related, but I'm a little bit confused, doctor, with the myelodysplastic syndrome and how it relates in relation to other kinds of cancer, such as T-cell lymphoma, and if that is a reason, the myelodysplastic, for not doing auto stem cell transplant. And I guess the second part of that is, in your experience, when you see a clean bone marrow biopsy and a patient who's reached remission, what other factors would you be looking at to make a decision on whether to do auto or allo? Thank you.
So again, it's not addressing a specific issue of a specific patient, so I'll just go one by one. So in patients with lymphoma particularly, many of them who would receive chemotherapy, 4 to 5 years down the road start having problems with their counts. And it's not very frequently. It's less than 2%. And these patients are found to have a myelodysplastic syndrome. Myelodysplastic syndrome is considered a quote-unquote pre-leukemia, although we consider it a type of blood cancer in which the patient has a marrow that's packed with cells, but their counts are very low. These cells have cytogenetic abnormalities, and they divide them in low risk or high risk depending on the chromosome abnormalities and the degree of cytopenia. Many patients with early myelodysplastic syndromes don't need to do anything, but if they required an autologous transplant because they had either relapsed for the lymphoma or for other orders, they would not be able to get it because the cells are obviously damaged, so they would be candidates for a donor transplant. In regards to the decision of auto or allo in the setting of relapsed lymphoma, that's a very difficult decision and one that many factors are taken into account. 1 is the quality of remission. 2 is the specific biologic subtype of the lymphoma. 3 is the duration of the remission. And then 4 is the quality of the bone marrow to be collected. And then obviously the availability or non-availability of donors in a specific patient. And many times there is a large discussion what the patient wants in regards to what they want the journey to look like. In many studies, when they've been compared head-to-head, the toxicity of the auto is much less, but the risk of relapse is much more. The toxicity of the allo is more, but the relapse rate is less. So you have to balance these different things to make the decision for an individual patient. And it is a frank-to-frank discussion between the patient, physician, and their family of what the patient's priorities are to help make the best decision. I hope that was helpful.
Yes, thank you.
Can you hear me?
Yes, please go ahead.
In regards to an allo transplant, I know you mentioned it briefly before, and once it relapses and it comes back, you recommended saying possibly just going with the same donor again for the transplant. I guess in your opinion, is that considered more successful than switching to another sibling, or what are the other options once after an allo transplant relapses?
So I think it's important to recognize that the question of what's the best donor for somebody who's relapsed after an allo transplant has not been settled. The only way to settle this is actually to do a randomized trial where the computer decides that you get the same donor, you get somebody else. That trial will never, ever, ever be done because it's just very logistically impossible for a question that many of us think, by the time we answer it, it will be irrelevant. So the decision of whether you use the same donor or not use the same donor is a very individual one between the patient and their transplant physician. Many of it depending on about whether the availability and the quality of the donor is available. On many situations, you can't choose. There is no better donor available, so you use the same donor. Intuitively, you said, well, if this donor didn't give me a graft versus leukemia effect, why don't we find another one? I think it is fair to say that the results are fairly similar one way or the other. If there had been a dramatic difference, because there have been large retrospective studies that really have not shown that dramatic of a difference. So personally, when I review my patients, I look because the one thing about the donor that was used is that donor is usually available. And if you want to go quickly, that might be important. But on the other hand, if the donor had trouble collecting, then you might want to use another donor. So there's various things that come into play to make the decision.
Thank you.
We'll move to our next question.
Hello. Hi. Yes, my name is Simone, and my husband was diagnosed with multiple myeloma back in April of last year, and he went through the bone marrow transplant in October of last year. What I don't understand is if multiple myeloma is, if there's no cure for it, what is the purpose of the bone marrow transplant really, and how will it help in dealing with the disease?
So that was an excellent question. So I think that autologous transplant for myeloma is the most common indication for autologous transplant at this time. The most common drug used is a drug called melphalan, which is given at very high doses. Melphalan at very high doses is the most effective way of achieving a complete remission of multiple myeloma today. And although I know everybody reads and hears that multiple myeloma is uncurable, the reality is that with high-dose melphalan autologous transplant, a third of each patient achieving a complete remission, which is 10% of the total, have not had to deal with their disease for more than 15 years. And it is the most effective way of achieving long-term disease control. Multiple randomized trials have compared patients who get early versus late transplant, and all of the trials show that patients who get transplant early have a better control of the disease in the initial part of their journey. And some of the trials show that these patients actually have a likelihood of living longer than if they had had the transplant later. So having said that, it is true that most patients who get high-dose melphalan will eventually relapse. In the context of high-dose melphalan and maintenance therapy, the average remission lasts 4 years. We are doing, through research, trying to find ways of making high-dose melphalan better and high-dose melphalan easier for the patients. We still have ways to go. But it is at this time a part of the standard of treatment, and I'm glad that your husband went on through it. And, his main benefit is that the high-dose melphalan got rid of disease that the other chemotherapy did not.
Okay, I understand. Thank you so much.
You're welcome.
We'll move to our next question.
Hello, my name is Marla, and I'm in sunny Florida. I was diagnosed with multiple myeloma in 2013. I had an autologous transplant in 2014, but I had partial remission. So I was put on maintenance of Revlimid, and then in December this past year, I was suddenly diagnosed with ALL. And, oh, by the way, everybody, there are studies now showing that if you are on maintenance with Revlimid for a while, that you will get leukemia. So you need to check with your caregiver oncologist with that. Okay, I have two questions. One is, you talk about survival rates, and you had said that the one for ALL is 50 to 60%. When you say survival rate, are you saying like death as a result of the process or lingering on later or what?
So, and I'm sorry you're having this complication. So it is true that lenalidomide maintenance does increase your risk of a second primary malignancy from 2%, which is the basis. So even had you not had lenalidomide maintenance, there is a risk of second cancers, to 6%. But despite that increase, lenalidomide maintenance has definitively improved the survival rates of patients with myeloma. So the average survival gain for a patient with myeloma who gets lenalidomide maintenance is approximately 7 years. And that's despite the increase in second primary malignancies. So, but I do think that we obviously educate our patients, that there is this risk. It's now incorporated in all the consent forms because it is important. Patients need to decide. And we're now trying to identify which patients have the highest risk of developing the complication that you had, and then based on that, deciding whether they should get lenalidomide maintenance or whether they should get alternative maintenance, which has been less established. Now, having said that, ALL is one of the secondary primary malignancies that have been described. The way it behaves depends on the cytogenetic abnormalities that it occurs and how it responds to initial therapy, particularly if you get MRD negativity. Now, in general, as opposed to childhood ALL, where we cure 90% of the people, in adult ALL, we only cure half of the people. And this means that you're alive free of disease at the 5 years. Does that mean your life expectancy is normal? The answer is no, because we do know that even leukemia survivors in an aggregate tend to live less than patients who are not leukemia survivors. And this is what Dulce spoke to you about. This is about, keeping on long-term follow-up with the transplant center and with your physicians is essential. Because some of the reasons why leukemia and transplant survivors live less than their peers are actually lifestyle choices. Because the chance of developing secondary cancers if you're a transplant survivor and you smoke is 10 times higher than if you don't smoke. If you don't take care of yourself and your cholesterol is high, the chances of having a heart event is significantly higher. And that's why a lot of the large transplant programs have developed, I don't like calling them survivorship clinics, I like calling them thrivership clinics or healthy living post-transplant clinic, because you really have to make a concerted decision of living healthy. Because what for other persons are maybe okay, I'm a little bit overweight, I'm not taking care of my blood pressure, but who cares, I feel great. For a transplant survivor, that decision may mean having a stroke 5 years later. And these are things that we can actually try to prevent and avoid. The same way as keeping a good record of vaccinations and being very proactive at the moment you get a first fever, you get a bad cold, to call and not try to say, I'm just going to string it along.
Okay. Now, you were speaking of, that you didn't have to have a perfect match to have a transplant. I have been through all 4 phases, which is 8 arms of chemotherapy for my ALL. So I've been in chemo since December. And I just finished it up. And for my transplant team, they check the National Registry when I call, and they still haven't found a donor. So I'm meeting with my oncologist this Thursday, and we're going to go and discuss a maintenance plan. So I guess my question to you in a generic sense is, what happens if they don't find a donor for you? What are your options, and what is your survival rate without having a transplant?
So I think here is where, so if there's not a perfect 10 out of 10 match, the question you should ask is there a possibility of doing a less than a perfect match using post-transplant cyclophosphamide as described by the group at Hopkins? With doing post-transplant cyclophosphamide in a less than perfect match, they can do a child, because your child's a half match, or they can do a mismatched unrelated donor on a national study that exists. If the transplant center where you are say, we don't do that, then you should request, could you refer me to a place where that is done? And I'm not going to go specifics into survivals of that area, because a lot of it, more than the mismatch, it depends on what the disease is doing. Because currently the outcomes of mismatched transplant with post-transplant cyclophosphamide seem to be very similar to the outcomes of patients with a full match, as long as the disease status is the same. And I am going to have to excuse myself because it's 1:03 over here in New York City. I really appreciate everybody's attention, but I have another meeting that they're waiting for me.
And thank you so much, Dr. Giralt, for joining us today. I want to thank everyone for joining us with this call. And as a reminder, this recording will be on our website in approximately about a week for those who wish to review it or to share it. And again, we would like to thank our sponsors and those that made this program possible, the Leukemia and Lymphoma Society and Genentech, as well as our LINK partners. Just so you know, our next Lunch and Learn program will focus on navigating and advocating for yourself on a transplant journey. This will occur on October 17th at 12 p.m. Eastern. Also, be sure to mark your calendar for some important webinars coming up. We have one September 26th regarding chronic graft versus host disease, and on October 9th, there will be one on understanding finances during the transplant journey. Registration information for these events will be sent to all who registered today. All programs are free and will also include an open question and answer period. If you would like further information about bone marrow transplant link, stem cell, or if there's anything we can do to support you, you can call us at 1-800-LINK-BMT, or you can also visit our website at www.nbmtLINK.org. Thank you so much, and you have a great day.
And that does conclude today's conference. Again, thank you for your participation.